So thank you all so much for being here and for having me speak on urinary tract infection, the epidemiology and prevention of. For those of you who don't know me, I am a geriatrician and I do work in long-term care. So I am sort of on the front lines with, I think, many of you in the long-term care setting. I have no disclosures. So the objectives are really, I think, very true to the title of this presentation. We're going to be discussing the epidemiology of urinary tract infection in this setting, and spending a lot of time thinking about, how the importance of standardized definitions for urinary tract infection really plays a big role in how we think about the epidemiology of urinary tract infection. And then spend most of our time discussing urinary tract infection prevention in this setting. I'm going to present two studies, one mostly associated with catheter-associated urinary tract infection, and then one for non-catheter-associated urinary tract infection, although I think principles from each study can apply to both infections and other infections. So why do we care so much about urinary tract infection in long-term care? And I know for me, this is something that I still hear. It's probably the #1 infection that I'm, hearing about in this setting. And I think, I'm not preaching to the choir here about the importance of looking at urinary tract infection in long-term care. But I wanted to present some data from, I guess it's a little bit older now, from February of 2014, the Office of the Inspector General report, where they went into a sampling of nursing homes and looked at those skilled nursing facility residents, or those sort of short stay residents, and looked at the most common causes of harm. And you can see here that infection, I don't know if this works. Yeah, infection was the most common cause of harm, so about 26%. But I think what really is important here is that the majority of infections were actually deemed to be preventable. And when you break it down even further, you can see that urinary tract infection was really preventable, right? So 71% of infections that were thought to cause, or that were, caused harm, were thought to be preventable. And so I'd like to use this data and talk about this when I'm, talking with my colleagues and other folks in our long-term care facilities, that, the reason we're still, caring so much about urinary tract infections is that they're still happening and they're preventable. So, we think urinary tract infection is the most common bacterial infection in long-term care facility residents. But, there's some challenges with how we're looking at, the prevalence of UTIs in this setting. Because if you're, do a literature search, a lot of times the criteria used to diagnose urinary tract infections are not consistent across many studies. So you're often comparing apples to oranges. And I think that really highlights the importance of, trying to have or thinking about having a more standardized definition for urinary tract infections, so you really know what you're measuring. Again, these are just kind of points that I like to, discuss with, my colleagues or my other clinicians in long-term care. And I know we all know this, but it's something I think we continue to have to remind others. Again, that, culture alone is not enough to track the true incidence of symptomatic urinary tract infection. And I like just to tell people these numbers because I think they're pretty impressive, right? So up to 50% of women in long-term care will have asymptomatic bacteriuria, or ASB. And I don't think a lot of people, at least it doesn't click with them that, it's actually that high of a rate. And I apologize, I didn't put the reference here, but I will add that. And then it approaches 100% in catheterized residents. The other issue, if you're kind of going through the literature, is that a lot of studies actually don't differentiate between catheter-associated urinary tract infections and non-catheter-associated symptomatic urinary tract infections. So again, it's really hard to compare. You're comparing apples to oranges. So here's an example. This is an older study, so from 2008, looking at the prevalence of nursing home-associated infections in the VA. So this was mostly men, but did include some women. And you can see here that symptomatic urinary tract infection was the most common most common infection, about almost 30% of all nursing home-associated infections, with a point prevalence of 1.58%. But when you kind of go through their methods, they did use surveillance criteria or sort of a more standardized definition, but then they added, or if a patient was on treatment for urinary tract infection or had a clinician-diagnosed urinary tract infection. So again, it kind of just highlights, when we initially look at this, we may think, okay, it's 28%, but it's hard to definitely know because of the way they're looking at the definition of urinary tract infection. So this was a study done at the CDC with, I think, probably some folks involved in the audience here, where they did a point prevalence survey of nursing home-associated infections in a few different nursing homes associated with the Emerging Infections Program. And they found about a 10% prevalence of urinary tract infections, so lower than I think some of the other studies have shown. But here they did use surveillance definition. So again, all of the diagnoses of urinary tract infection actually met that NHSN definition. What's interesting here is that when they looked at, those that met the surveillance definition and those that were treated, there was a really big discrepancy. So I think it was 50 patients or so or residents were on treatment for urinary tract infection, whereas only 6 actually met that definition. So a pretty big gap there. And I'm not going to go over these in too much detail because I think Angela is going to talk a lot about this next, but I wanted to just highlight, on the left here is the sort of the, updated McGeer criteria, which NHSN is based off of. But there's also something called the Lobe Criteria. Have folks in the room heard of Lobe? Yeah. So the Lobe criteria is more used for, it's a more clinical definition, and it's to assist clinicians with ordering the minimum criteria to order antibiotics for infection. So there are some differences, but I just wanted you to be aware that there's, if you're kind of looking through different studies or you're, talking with clinicians, that there's sort of the more surveillance definition and then a more clinical definition. The Lobe criteria is a little older. It's from 2001. It is in the process of being updated, but probably won't be out for another year or so. Okay. So I talked about sort of that discrepancy between, positive culture or being treated for urinary tract infection and then those that actually meet a definition. And I think this study really highlights why it's so critical to have a standardized definition so that we can compare, one study to the next. And so this was done in 2012, and here they looked at urinary tract infections and pneumonia. Oops. So that's over here, and this column is devices, this column is non-devices. And they looked at how many patients were either being diagnosed and treated by a clinician, and again, how many met either that updated McGeer criteria or the NHSN surveillance definition or the Lobe criteria. And not many, so only 33 out of 146, so that's 23%. So you could say, well, somebody is saying that there's 146 urinary tract infections or pneumonia in this, this population, whereas, only actually 33 met those definitions. So kind of, I think, really highlights the importance of what we're doing. So kind of on that track, it's so important to have that, sort of standardization because we want to be able to track how well our, prevention efforts. And it's really hard to fix a problem if you can't accurately, measure a problem. And so I'm going to talk now about, again, prevention of urinary tract infections, both with urinary catheters and those without urinary catheters. So this was a pretty recent study, just came out in 2017, and a pretty large study. And Namali was actually involved in this, and so you can comment, please, if needed. And so this was a large implementation project over the course of 2 years. It was funded by AHRQ, and it was implementation project to prevent catheter-associated urinary tract infections in nursing home residents. Now, there were several different components to this study. There was a technical bundle, and in this sort of technical bundle, they did a lot of education and provided a lot of, knowledge and material associated with appropriate catheter removal, aseptic insertion of, and training with aseptic insertion of catheters, using regular assessments, training for catheter care, and incontinence care planning. And I'll show you a little bit more in the next slide of that technical bundle. But they also had a pretty large socio-adaptive intervention, and I think that this is sometimes that we don't always think about how important this component is to prevention. And this really spent time enhancing attitudes and behaviors related to infection prevention practices. So, doing things like creating safety teams and engaging leadership and those frontline staff and residents. And I think really largely enhancing communication, because that's one thing that I find is not always the best in long-term care, because you often have clinicians who are aren't there regularly. They come in and then they leave. There's a lot of turnover, and so it kind of gave strategies to help enhance that communication, and really helped the frontline staff feel confident enough to speak up if they saw something or had questions about something. And it was actually a pretty impressive study. So they started out, on the y-axis here is a catheter-associated urinary tract infections per 1,000 catheter days, and on the x-axis is the program months. And all these lines are just, I guess, varying amounts of data, but we'll take them sort of all together for the purpose of this. And you can see here that there are about over 300 catheter-associated urinary tract infections at the beginning, and it decreased, I think, about, looks like 50%, so a little bit under 200 at the end of the study. So it's a pretty positive implementation project. And I will say that they did use NHSN surveillance definitions at both the beginning and the end of the study. So it wasn't like, they were using that clinician treated or on an antibiotic and then use surveillance definitions at the end. It was consistent throughout. And this is just some of the tools and some of the graphics that they used, and I particularly like this one. Again, it kind of focused on those 5 components. And here it's been there was a lot of sort of fact-based information about, appropriate use of catheters. And so I think, we all know that we're not supposed to use catheters for incontinence, but I think it's still a really big problem. And so there's a, big section on, how to, appropriately, how to do incontinence care planning, and, what are the appropriate reasons for catheter use, and how do you do regular assessments to make sure that, catheters are taken out when they're not needed. And I think over the past decade or so, we've done a better job in the acute care setting of getting catheters out when they're not needed and not putting them in. But I think it's still an issue in long-term care, and I'm not sure if you guys in the field see this still a lot, but I certainly do, especially as it relates to incontinence. So this is just an example, and actually if you go to their website, which is right here, there's a lot of information. I will say that the website can be difficult to navigate at first, so you have to get a little bit comfortable with it, but and I can't go into depth of any of these tools, but I just put a couple up here, and the website down there if you want to take a little bit or go a little bit deeper into some of these tools. So they have things that, about how to implement just an infection prevention quality improvement project, and again that translates to other infections as well. That important component of improving safety culture, how to engage your residents and families, how do you get them to speak up, get them to enhance communication back and forth. Just practice general infection prevention skills, the prevention specifically of catheter-associated urinary tract infections, and then a large component on urinary tract infection surveillance, which we're also going to go into a lot over the next hour or so. And then I'm going to talk a little bit here about reducing unnecessary urine culturing and overuse of antibiotics. And so we hear a lot about antibiotic stewardship and how to decrease the use of antibiotic use. And I think we talk a little bit less about diagnostic stewardship. And that was a really important component of this study, was just the ability to reduce the amount of urine cultures being ordered. So I can say as a geriatrician, it's a lot easier to not do something if you don't have this 100,000 colonies of ESBL in front of you. And so they really focused on, just don't order the culture if you don't need it. And I think we need to make sure that, our colleagues in long-term care, in addition to antibiotic stewardship, really focus on that diagnostic stewardship component. And this was one of the sort of graphics that they used, and it had 4 things you should know about urine cultures. And I really like this, actually. So, I think it's, to even show this to, your frontline staff or clinicians or some of my colleagues, and even maybe some patients and residents, because it just kind of, describes, I think, a little bit more simply that idea of asymptomatic bacteria and catheter-associated urinary tract infection. And then it gives here these, inappropriate triggers for urine cultures. And I don't know about those in the audience, but that still happens so much in some of our facilities where, either it's a clinician will say, oh, or the frontline staff or a resident, oh, my urine smells, I need that urine culture. And then it kind of goes down the path. So I really like this. Again, you can get to this graph and this graphic and many others through that website on the previous page. And then it also gives sort of examples which follows the surveillance definition of when to actually order a urine culture and when might be an appropriate time. It's also nice because it's like something to point to, so especially with some of my some who may are still kind of, learning about this and thinking about it. It's just a nice, kind of thing to actually point to and say, well, no, here. And, I think this highlights just like the importance of what we're doing and why surveillance is so important. Because, we want to know, how well our prevention efforts are working, right? So what are the results of our efforts? And we can really only do that if we're doing surveillance. And so are we tracking catheter days? Are we tracking how many urine cultures there are ordered per month? Are we tracking antibiotic starts per month? And again, this is another graphic from their website, but it, just kind of, I think, just highlights again that importance of, why we're doing what we're doing and why we need to do what we're doing to show how well our prevention efforts are working. And then, reducing patient harm. Again, this is mostly just for your reference, just as an easy way. I put out a couple of the exact links that I thought were the most useful. So the first is related to implementation. The second is related to sustainability. So how do you, after you're implementing this and you find a reduction, you find that your efforts are working, how do you keep that going? And this can be something that's pretty challenging, but I think some of the resources here are pretty helpful. And then this is just a general resource section. Okay, so now we're going to talk about cranberries. Do you guys still get questions about cranberries? Yes, everybody. I get questions about cranberries all the time. So, decades or even maybe centuries, people have been using cranberry juice for prevention of urinary tract infection. And I think in the 90s, there was a few studies that did show that drinking 10 ounces of cranberry juice did reduce bacteria and pyorrhea in older adults. The problem with that study was that it was really hard to get older adults to drink 10 ounces of cranberry juice. So in 2016, Manisha Dutani took this to another level. So they tested cranberry capsules. So they used the component of cranberry that was in the cranberry juice. It's something called like proanthracycline, PAC. And they took that and they put it in a capsule form because they thought, well, it'll be easier for people to just take a pill than to make sure everybody's drinking that 10 ounces of cranberry juice. And they looked at its effects on the reduction of bacteria and pyuria. And I'll highlight that it was just pyuria and bacteria, so inflammation and bacteria in the urine, not necessarily a symptomatic urinary tract infection. And that was primarily because it's just really hard to get to do that. And so they were kind of using that positive culture as a proxy. And they looked at women aged over 65 years who were in 21 different nursing homes in the Connecticut area. And unfortunately, it didn't show anything, and I think they were pretty disappointed. So there's really no difference on the incidence of bacteria and pyuria compared with placebo. I will say that the cranberry industry was not happy about this study at all. I think Venetia got death threats from ocean spray. Not really, but they were not happy. I think there was a lot of editorials after about why this was not a good thing. And this is just the graph of what they found. So on the y-axis here is the percent of bacteria or positive specimens, and then on the x-axis is the months, and the green circles are cranberry capsules, and the white are placebo, and there was really no difference. So what do I say for cranberries? I'd say it probably doesn't hurt, right? So I think one of the most important things probably, or maybe not the most important thing, but something that probably helped with the cranberry juice was just that component of hydration. And I actually like it too because a lot of my patients are old and they don't eat a lot, and so it gives them calories. So I think it's great. If somebody wants to try it and they like cranberry juice and they need to gain some weight, I think it's a great tool or a great intervention. I definitely don't recommend, I get asked sometimes, oh, should we just put everybody on cranberry capsules? And I definitely don't recommend that. I mean, it's another pill, and we don't have any evidence to say that it actually works. If individual patients or families, don't want to drink the juice, but they want to try cranberry capsule, I say, fine, sure, let's try it. But it's not something I necessarily recommend. I probably would just do the cranberry juice because it gets them to drink a little bit more. And again, the calories is so important for many older adults. So there's a couple things too, and I'm sorry the image of the water. I was trying to find an image of water, but there's one that was not copyrighted, and this was it. So, there's less data, I think, behind, but I think it's more intuitive behind things like hydration and nutrition and good hygiene and encouraging good voiding habits and, improving functional status. Anecdotally, I think these are probably the most important thing. If you're laying in bed and you're incontinent and then you're incontinent of stool, you're definitely probably at much more higher risk of getting a urinary tract infection than if you're up and you're sitting in a chair, or you're walking, or and you're getting changed appropriately, or your sanitary pads and diapers are getting changed regularly. So I think this makes sense. There's a little bit less, I think, data, hard data to support a lot of this, but it's certainly not going to hurt and helps in many, many different ways. Oh, and I'll just mention here too this, the whole incontinence care, and I talked about that for the prevention of catheter-associated urinary tract infections. And again, I don't know, how much, hard evidence there is around it, but even that idea of scheduled sort of toileting and helping residents go to the bathroom every 3 or 4 hours, I'm not sure necessarily there's, prevents urinary tract infection, but it kind of helps, I think, with the, the reduction of use of catheters, and I think it kind of just helps patients and families kind of feel better about things. They're getting up, they're going to the bathroom, and so I think overall it probably leads to less urine cultures being ordered. Okay, so in conclusion, and we'll have a few minutes left for comments or questions. Urinary tract infections are common, and they're a significant cause of harm in long-term care facilities. And I think that's something that we have to continue to, tell our, other folks in long-term care, and I certainly tell my, co-clinicians and our staff, our frontline staff, and our leadership that the reason we're still talking about this and the reason what we're doing is so important is because they're still happening, and they cause a lot of harm, and they're preventable. So this is like a really good area to target because they're preventable. Not always, but often. I think with NHSN and more people reporting into NHSN, we're going to have a better idea of how common urinary tract infections actually are. But I just wanted you to be cautious if you're kind of looking through the literature or even using some of the MDS data. I'm not sure that's a total accurate estimate of what your total urinary tract infections are, because we know there's such a huge discrepancy between surveillance and sort of more standardized definitions and what clinicians are treating and or what those positive urine cultures. There are evidence-based approaches for reducing urinary tract infections in long-term care, and those should be utilized. I think a lot of the data is more surrounded catheter-associated urinary tract infections, but again, those principles on patient safety and enhanced communication, I think, apply to any infection, and certainly non-catheter-associated symptomatic urinary tract infections. And then drink up again. So I think hydration, getting people up, getting people moving, again, are not easy. It would be so much easier to give everybody a cranberry pill, but that doesn't necessarily work, and so it's kind of all these other things surrounding infection prevention that are really what helps. So with that, I am done.
If there are any questions in the audience, please find a standing mic. We do have one question from the web. We have gotten our medical director on board with no longer irrigating catheters, not CBI. However, our urology department still uses this as a common practice. So I don't know if that's a question or a comment.
Yeah, I agree. I think, there are, I think more recently, I think there's some, a little bit more communication between urology and long-term care. So I think hopefully those, getting on urologic departments and societies, or hopefully we're aligning our what we're doing a little bit better. And I kind of thought I saw something more recently about I'm not sure. Never mind. But hopefully that we're aligning. But yes, I agree. It still can be an issue.
Great. Any questions?
Hi, great presentation, thank you. And I wanted to mention, as I recall in those earlier, I'm from New England, so I have to defend the cranberry industry, but I remember in that earlier work too that you could cut the cranberry with something like ginger ale, I thought would be all right, because cranberry juice is tough.
Yeah.
So, and the other question I had, it comes up constantly, is distinguishing surveillance criteria from clinical criteria, because I hear McGeer, they seem quite well aligned with McGeer. So is it reasonable for people to, you had McGeer and Lobe lined up there. Can you use McGeer as clinical criteria as well?
Yeah, that's a great question. I mean, I think, certainly they were developed for surveillance purposes, but I do think they're kind of the gold standard, right? So, I think the majority of urinary tract infections will actually meet all of those components. The Lobe criteria, again, was really made for kind of the threshold to start antibiotics, right? So, if you meet the McGeer or the Lobe criteria, it might actually not mean that you have a urinary tract infection, but it might mean at that time that you kind of meet that threshold for antibiotics. But I agree. I mean, I think that's our gold standard. That's what we think, if you have a urinary tract infection, you should have pretty much always those components. So, yeah. And I think that's one thing why surveillance, again, is so helpful, because, as clinicians are, looking at this and seeing these, criteria, it helps them helps remind them when they're assessing patients, oh, are they meeting all of these elements? Yes, right, yes, culture, yeah, exactly.
A question about the study that was done, that was finished in 2017. Was there any commonalities amongst the patients who remained and continued to get the UTIs? Because there was a significant decrease,
Yeah.
but were there any other things implemented afterwards? Is there anything in the works for new education or that would take it down even more?
Yeah, I don't know that. Damali, do you know?
Excuse me. Thank you.
Thanks. It's a great question, whether there were factors at the resident level, is what you're getting at. And the reality is, the way this project was deployed, it was really, there were state level or regional coaches working with a group of centers, and all of the data rolling up to the national project team was really an aggregate. So nobody doing the final analysis could get down to the level of the resident factors to ask that question of, well, when they did still have events, was there something about the people having clinical UTIs, symptomatic CAUTIs, that was different from the people that they were able to either remove the catheters out of or prevent symptoms from developing? The centers would have perhaps data on hand to look at that. And I would argue that those of you that are reporting into NHSN and using the UTI surveillance module could start to drill into who are the residents that are developing symptomatic events and what is unique about them. There's always like a tension between how much data do you collect on each individual event versus just the burden of having to go into the chart and try to find all of that information. So I think at a system level, NHSN tries not to ask too much about the resident level information. However, there's enough there that if you, as part of a performance improvement initiative, said, okay, for the next 3 months, we're going to dive into our CAUTIs and look at a little bit more, gather a little bit more information, and Angela might tell you how to do custom fields so you could capture more about those patients or residents at the time. There may be unique factors that we're not accounting for in our general surveillance criteria that you would see. But at a project level, we never got that much resident-specific information to answer the question. But it's a very good question. And I think one of the things we hope people doing surveillance ultimately will do is when you see, for example, wow, all my C. diff is happening in my skilled unit. I wonder what my antibiotic use is looking like on that unit. Is there something about that unit that is different from my long stay that explains? You actually can dig deeper into those events once you see them. And I just want to make the point that we get this question a lot about, can revised McGeer definitions be used for clinical decision making? And 100% the answer is yes, except the big difference is most surveillance criteria are applied after all of the information is back, right? Including the laboratory data, including the culture results. And the one thing I worry about is that a provider would say, I'm not going to start antibiotics until they meet all of the surveillance criteria, which means I wait 3 days for my culture results to come back, and that would be a mistake. So I think the big caution is saying, use the clinical criteria: fever, localizing signs and symptoms, dysuria, frequency. Perfect. You document those, that's very legit to start an antibiotic, but don't wait and delay treatment trying to make sure that they end up having a positive culture, because you could inappropriately mismanage somebody with a true infection, right? So that's the caveat to using the surveillance criteria. But otherwise, I agree 100% that they do line up quite well. And it's reasonable if you're teaching people what to assess and how to evaluate using the criteria, that's what you would then prompt them to think about clinical treatment. Does that make sense?
Thank you.
So antibiotic prophylaxis or for UTI? Sure, in the long-term care setting. So I think most of the data has been for use of antibiotic prophylaxis has been in a younger population and more of an outpatient population. And there may be some data to suggest that it does reduce symptomatic urinary tract infection in that sort of specialized population. I don't use it in long-term care because I don't think we have a lot of evidence to say that it actually prevents urinary tract infection, and we certainly know that it can lead to antibiotic resistance. And the common antibiotics that we use for prophylaxis are also can generally be toxic to older adults if they're used. So I do not recommend antibiotic prophylaxis. I will not say that I've never, ever, ever, ever done it, but in general, it's not one of my first go-to strategies. Because I think it causes more harm than good, and we certainly know that it causes antibiotic resistance. And even in the younger patient population, in those when they found that it may, reduce the recurrent urinary tract infections, those patients who were taking antibiotic prophylaxis did have increasingly resistant urine cultures over time. So, I think. Yes. Oh, I think there's someone back there too.
I had another question that kind of followed with that, and that is, when Namali was talking about that period when you're waiting for the culture to come back, and if you want to prophylactically, I guess, empirically, sorry, thank you, start something. And I know facilities are trying to get antibiograms up and running. And what we're seeing in New Hampshire, I just wanted to point out, was we had a statewide antibiogram created. And then it was produced by the Department of Public Health with various caveats of how you might approach it. And what we're finding is New Hampshire is a very small state. And what we're seeing is patterns statewide that really reflect what's going on in the whole state. So people can basically use some general recommendations from this for treatment. And I think what they found was that Bactrim and Furidantin were the two drugs that were still pretty good for empiric treatment. I've heard some downside on Furidantin, and I wondered if you could speak to that from the physician perspective.
Sure. So that, I don't know, I have a minute or two. So nitrofurantoin has kind of been out of favor and then in favor. So nitrofurantoin is really good against E. coli, and we're actually finding that it's pretty safe in older people. So it was on the Beers criteria list for a while, and I think now it is officially off. And we didn't think it was as effective for residents who have a lower GFR or impaired kidney function. But we're finding that, I think there's 2 or 3 studies that came out kind of recently and said that's probably not true. So I use nitrofurantoin actually pretty regularly if I suspect a E. coli urinary tract infection. Other Enterobacteriaceae sometimes have inherent resistance to nitrofurantoin, and so if you're expecting like a Klebsiella or a different type of non-E. coli bacteria, it's not always the best to use. But I think overall, in most residents, it's probably pretty safe. And hopefully there'll be some more guidance coming out about that somewhat recently, or in the near future. And one other just quick point I wanted to comment about the prophylactic UTIs. A lot of times when I get questions about should I use prophylactic antibiotics for recurrent urinary tract infections, those residents don't have recurrent urinary tract infections. So I think that's like the one thing to highlight too, is a lot of times they actually just have had a lot of urine cultures, but they don't actually have recurrent urinary tract infections. So, yep.